In this video, we're going to look at some aspects of groin rehabilitation and the challenges it presents to us as rehabilitation professionals. It's part of an extract of a groin course, which I'll describe in more detail to you later. But there are particular issues which the groin presents from a rehabilitation perspective, which pose some challenges, and we need to have some tactics and techniques available to us to overcome these challenges. The first of these, of course, is the differential diagnostic challenge, and apart from the role of imaging, which we'll discuss later, a lot of the evaluation of pain related to groin problems are clinical diagnoses. So imaging can help to assist with specific kind of pathological differentiation, but in most groin related problems the imaging doesn't give us a great extra insight into how we go about rehabilitation. The other issue which we need to recognise, of course, is that it is an area which is notoriously unpredictable in its response. So when we see an acute groin presentation, it's very hard to predict from initial examination, is this going to be a problem that we're still looking at 2 or 3 months down the track, or is it going to be a problem where the patient is rehabilitated within 1 or 2 follow-ups. And it's also a region where there are notorious bottlenecks and rehabilitation plateaus, where we achieve certain functional objectives, but it proves difficult or challenging to progress to the next level without provoking symptoms. So we need to have some strategies and techniques available to us to try to move beyond those bottlenecks and plateaus if and when they present themselves. In terms of the diagnostic dilemmas that we face, the main issues really centre around the non-specificity of provocation tests. So provocation tests where we use the hip as a lever, or stress the lumbar spine, or do active resisted tests on the musculature, stress multiple tissues simultaneously. So it is hard to be conclusive about positive results when we know that there are multiple tissues stressed simultaneously. The other issue, of course, is that there is frequently coexisting pathology. It may be infrapubic along the adductors, the tendons and the muscular tendinous structures. It may be pubic symphysis, and it may be suprapubic involving the rectus abdominis, the abdominal sheath and the conjoint tendon, and of course involving lumbar spine and associated nerves as well. So there is often a spectrum of coexisting pathology which may have a common link in terms of functional breakdown, but they may represent different components of a more global functional breakdown, which obviously as therapists we need to identify and challenge. So from a therapeutic perspective, we need to be aware that there are frequently multifactorial contributory factors, that they may fit into either intrinsic or extrinsic categorizations. Now, the extrinsic factors are more easy to identify in terms of training volume, training technique, alterations in terrain and footwear and so on, where really the clinical challenge is ironing out what intrinsic mechanisms are involved with the patient's breakdown. And for us to pursue these strategies, we're often left having to apply real-world clinical strategies where there is a limited evidence base to draw from. So we often have to follow clinical intuition and obviously extrapolating as best we can from the scientific data available, but unfortunately we often don't have the confidence of having precise protocols which direct every step of the way. But this, of course, is why it makes it such a challenging area. But on that basis, the implication then really is that rehabilitation should be mechanism driven as opposed to diagnosis driven. So we need to try to evaluate what the mechanism of breakdown is, rather than being totally preoccupied with actually the structure that has actually failed. The exceptions to this are, of course, if the actual structure that has failed requires some sort of surgical intervention. But if that has been eliminated, then really the onus on us as therapists is to identify the mechanism of breakdown and identify strategies to address those deficits. Now, you may say, well, why go through this length of analysis for groin problems? Because we have well-established groin rehab protocols that involve isometric static muscle contractions, involving stretching protocols, and then progress through a sequence of loading from low-impact leg endurance work through to jogging, through to sprinting, higher intensities in straight line, and then looking at directional change. Now, those kind of very standard protocols will work for the non-complex groin problem, which isn't really posing a rehabilitation challenge. The content of this module and this course, which we'll describe again later, is really geared towards patients who don't follow that relatively simple, straightforward rehabilitation pathway. So we may well choose to start along each of these components, but we need to recognize if patients aren't responding at the appropriate rate, to then start to broaden our rehabilitation concepts and integrate more complex ideas into our rehabilitation regime. This is a fairly active slide in which I've broken down many of the different components which we need to think about when we're looking at the differential diagnostic spectrum, and we need to consider issues under the categorization of muscle breakdown, which can involve the inductors, the iliopsoas, the rectus femoris, iliotibial band, and rectus abdominis. So they will be the commonest muscle groups involved. The tendons of those muscles may also be involved: the adductor longus tendon, the magnus, the hamstring insertion, and gracilis and pectineus. So the muscular tendinous structures are our first priority to identify. Are they symptomatic and part of the symptom pattern? With regards to joints, we need to look at pubic symphysis. We need to look at the possibility of mechanical symphysis irritation, or in fact degenerative change, which is in fact osteitis pubis. And the hip, sacroiliac joint, and lumbar spine also are an integral part of the functional unit. There are specific red flag areas, particularly in young athletes: the slip femoral epiphysis, or in elite endurance runners, pubic ramus stress fractures and sacrum stress fractures, and indeed a vascular necrosis. These are things in which imaging would be an essential prerequisite. Some of the less frequently talked about issues would be things such as nerve entrapments, the obturator, ilioinguinal, iliohypogastric, genitofemoral, and piriformis syndromes, but they of course are often part of coexisting pathology, and we need to recognise their presence in the symptom patterns. Inflammatory conditions such as inflammatory arthritis, the infamous sports hernia, of which so much has been written about, and yet the diagnostic criteria are still somewhat vague in my opinion. Bursitis, snapping hip, and labral pathology. These are all frequent findings that we need to differentiate because the management strategies are different. And of course, in the medical dysfunction category, things like hydrocele, epididymitis, inguinal hernia, and sports hernias are potential contributory factors. From a physiotherapy perspective, the first priority is to establish whether we need onward surgical referral because of the nature of the problem. Sometimes this can be established with the assistance of imaging, such as herniography, or if a stress factor is suspected, bone scan or x-ray, but that will depend on the onset of symptoms. But many times in the clinical practice we don't have immediate access to imaging, so we have to make some clinical management. But essentially, unless there is a specific surgical protocol required, we're generally looking at some sort of conservative management protocol, and the clinical challenges are to determine the timescale of rehabilitation, the rehabilitation strategies involved, and the prognosis for the patient. We discussed these concepts in much more detail over on the Physio Digest website, and there is a 1-hour lecture available there which is part of a series on the anatomy of groin failure, which is the first in a series of groin rehabilitation lectures. So if you're interested in this area, head on over to physiodigest.com and have a look at the course content and see if it's something that would be interesting for you. Hope to see you over there. Bye for now.